We will go through the case discussion part. Let me introduce the panelists, Dr. Likhit, Dr. Norishad, and Dr. Gulapat to be the panelists. And for the first case of the case discussion would be in the topic of periprosthetic fracture that will be presented by Dr. Pronpanit Disanivet.
Okay. Good morning, Chairman, Co-Chairman, and all participants. I have a case about periprosthetic fracture. So this case is a 68-year-old female patient. The history is she has underwent the bipolar hemiarthroplasty due to the femoral neck fracture 10 years ago. And then in the last year, she has a progressive like groin pain and was diagnosed as a loosening of the implant. So the patient, the doctor, he decided to operate the patient by doing the revision total hip arthroplasty. However, there are problems in intraoperative, and the doctor he decided to send the patient to me. So the patient have no underlying disease and no any history of allergy. This is the X-ray when I first saw the patient. So as what I know is when the doctor he tried to did the total hip arthroplasty, when he broached the femoral canal, first time is broke. Then he tried to use the longer stem and he also broke it. It's also broke. So this is the shape of the femur. When I first saw the patient, there are fracture somewhere here and comminuted around here. And there are also cracks along the middle segment. It's like a comminuted in the middle shaft of the fracture. So, and also the acetabular cup is like a protrusion. Look like this. When I send the patient to the CT scan, this is the all information I have. So, what you do for this patient?
I have a question about she has a pain for a year, right?
Yes.
And what about the histology in the first operation about the infection?
No history of infection.
Did they send for the histology?
Yes. No
Confirm that it's not-
evidence of the infection. Yeah.
I see the cup is look quite protrusive
Yes.
inside.
Yes.
Is that happen during the total hip replacement or it's already protrusive in with the bipolar?
I'm not sure because I don't have the first X-ray of the patient.
So let's say that the acetabulum is a new fracture, right?
Yep.
It's
Maybe.
new.
So if you confirm about there's no infection inside, the concept would be the fixing the whole bone, either by the long prosthesis or the long implant, and also addressing the protrusion of the acetabular cup. I think we have to plan quite more meticulously because sometimes we have to use the augmentation at the acetabular cup, either by the some type of the metal augmentation, the highly porous metal augmentation, or even some type of the allograft, or even the 3D printing of the metal. It's quite difficult in this case.
So was the question that what is the final management, right?
Yeah.
Okay. So in my opinion, for the acetabular side, we have to separate the two problems. That for the acetabular side, should be like a. Can you go back to the CT scan?
Yes.
it looks like it's a protrusion of the, and with a breakage of the posterior column. So it's likely that the acetabulum is not stable for the prosthesis to stay, and in my opinion, I prefer to do a bone grafting and with a spotting ring, and might use a cemented cup. And for at a femur, as I mentioned about the fixation, also can go to the film of the femoral shaft, please. Because the fracture is really long, it's extended from the isthmus toward the supracondylar area. So, and the bone stock above is not so good, and it's also I think the fracture line extend toward to the proximal metaphysis also, and I might use a cemented stem with placing the distal femoral LCP to overlap the cemented stem above. This is my opinion. Thanks.
Let's go to the CT scan of the
Okay.
acetabulum again. I'm not sure that the acetabulum is look protochial. I'm not sure that it's a already malunion from the bipolar or a new fracture or not. Let's say if a new fracture of the acetabulum with a protochial situation, like in this case, I think the column is fractured. The posterior column is definitely to be fixed if we want to put the cup, acetabulum cup in. I think I'm go to posterior and fix the posterior column and check that I can get the medial wall, the quadrilateral plate in the anatomical position or not. I try to make most anatomical of the quadrilateral plate as much as possible. And because it's very high risk of recurrent protochial, from the arthroplasty concept, you have to bridging the posterior and the anterior by using the anti-protochial cage. You can put the bone graft in, put the anti-protochial cage, and put the cemented cup. I think that I would do for the acetabulum. And about the femur, there are fracture line at the proximal and the distal at the tip of the plate. Because the age of the patient is quite old, I prefer to use a standard cemented stem with the distal femoral locking plate from the distal along to go to the tip of the GT. That's my opinion.
For me, as Dr. Gulapat mentioned about the fracture of the posterior column, is there any fracture line at the posterior
No.
column? No,
Just only protochial.
Only polytochial. So yeah, I have addressed all the issue about acetabulum already. So could you go back to the femoral fractures? So I quite worry about the maybe go to the long X-ray, the femurs. Okay, I think it is quite difficult to try to fix with the similar stems as the panel mentions. Because it's quite hollow at the femoral canal, and I'm not quite sure whether the Wagner stem would be quite possible to fix the rest of the area and quite secure the load transfer from the hip to the knee. So I rather choose the cemented stem as the panel mentioned and do a more secure fixation to the by using the implant to secure the fixation of the distal fractures and the proximal ones, maybe up to the greater trochanter. As I mentioned in my slide, there's a plate that can extend up to the greater trochanter and down to the supracondylar, even the condylar area of the femurs.
Okay. I think may have the question that the patient is quite too old and they also have the fracture as distal femur also. Do we need to do abrasion in the 1 or 2 stage? So that a fixation first and then keep the bone heal, and then doing arthroplasty is maybe easier than than one state, as you say, for the panelists.
Okay, so may I proceed? Okay, so first, when I saw this patient, I discussed with the arthroplasty guy in my team. So we think that the femoral fracture, they have fracture around here, and also the distal shaft, and also comminute in the middle shaft. So it looks like the bone stock for the femoral is only on the trochanteric area and at the distal part of the femur. So as we discussed, so we think that there is quite difficult for the implant to be stable in this femur shaft. So we decided to do the two-stage operation. In the first stage, we tried to make the bone heal first. So we did the retrograde nailing. So we set up the patient in the lateral decubitus position, and they take off the acetabular cuff. I press the nail and fix here at the distal part, and also we put the nail a bit too proximal than normal because there is no bone stock allowed here. So we have to fix it at the GT, at the trochanter area, and we put the cemented at the femoral head, and we also treat her with the osteoporotic duct, teric. So 6 months later, fortunately, the proximal part is healed, the shaft is look healed nicely, but the distal part is not healed yet. But at this time, so we decide it's a good time for we to proceed to the second operation. So in the second stage, after CT scan to confirm the healing of the proximal and the middle part of the femur, so we decide to do the total hip arthroplasty. We revise the stem a bit and put the screw a bit upward. Also for the shaft, we bridging plate at the distal part of the femur and cover some part overlap to the prosthesis. And this is 3 months later. So the fracture look is increased consolidation at the distal part, and hope you heal nicely. Thank you.
Sorry for the doctor for a minute. จะถามมาหน่อย You discuss about the first fixation that will be a nail or plate. If we go for in plate at the first stage, it maybe do not need to remove the nail while doing arthroplasty in the second stage. What do you think about plate nail in the selection and at the first stage?
Okay. So at the first stage, we use the nail because I think that for the nail, so we can preserve some part of the femoral canals. So for the next operation, if there are operatory of the canal, so it may difficult for arthroplasty. So that is the one reason that we use the nail. Another one is because the fracture is quite long and it's comminute in the middle part. So I think the biomechanic for the nail is more superior than the plate. Also.
Yes, sir. Thank you. That is an important factor because of if you put the plate in with maybe mid-bone technique and we not preserve the canal, it's very hard to do the second operation. It's also a quite important factor to decision making. Thank you.
Thank you, Dr. Phornpinit. The next case discussion from Dr. Panawat Sila Wattananai นะครับ Peri-implant fracture ครับ
Okay. Good morning, everyone, chairman, co-chairman, and all panelists. It's an honor to be here to present the case peri-implant fracture. Let's start with a bit background of this patient. 77 years old with history of significant osteoporosis. Underlying is renal failure on dialysis, CAD, hypertension, and dyslipidemia. She was fall from standing high ground level and a history of PFNA around 8 years ago. The X-ray reveals the distal femoral fracture around the tip of PFNA. The pre-injury film, the fracture was managed with PFNA, a common standard choice of this injury 8 years ago. She's doing well after operation. Okay, I will show the CTs for assessing the fracture. We sit here along the whole femur to assess that there are no fracture around the old implant. Oh, sorry, go back. Okay, for clear picture, highlight complexity of the fracture relation to the implant. So to wrap up, this patient low energy fall with significant osteoporosis. There are some the challenge point that are very short segment, severe osteoporosis, and some comminution. Okay, I want to ask all the panelists about the plan of the strategy of this case.
Okay, after the CT scan, I think that intratrochanteric fracture has healed completely, and I think that for the new fracture that is a low supracondylar fracture without the interarticular extension, is extraarticular, and
Yes.
the bone quality quite poor. For my choice is I will retain the previous fixation, and will use the plate for the stabilization of the new fracture. The question is one plate or two plate. I think for me, one might not sufficient. I will consider the distal femoral LCP and a medial side with I will use maybe a Philos plate to use a reverse configuration.
Please. I have to refer to the classifications that I have been mentioned. Are there any healing of the proximal part?
Yes, it's already here.
Yeah, 8 years ago.
8 years ago.
Okay, it's now we have to attack just only the distal part.
Yes.
Also, you mentioned there's quite osteopenia of the bone.
Yeah.
As I refer to my lectures, the Fernando guideline of the treatments, they try to put another implant without interfering with the old implant if there is no need to. So the Fernando will try just only the plate. If there is no secure fixation, just only from the lateral side of the plate, they're gonna put another side on the medial one. That is some that I have guideline. But anyhow, if you like to secure more, sometimes we put the retrograde nail by remove the PFNA out and put the retrograde together with the lateral locking, distal femoral locking plate. That's all.
I think the intertrochanteric fracture is already union, so we have not too concerned much about the intertroch. The problem is that the distal femur. With this fracture, I think I maybe back up. I definitely put a plate. I'm the plate guy. the plate on the lateral side and maybe prepare the medial plate too because the segment is quite low. About the nail, actually from the classification, if the fracture is already healed, maybe you can remove the nail and put the plate at the distal femoral plate in. But sometimes, for me, I a bit concerned if the PFA is gonna remove because it's gonna have a big hole at the proximal part after the nail is removed. For me, I will put the longest lateral plate as much as possible, and bending the plate proximal and put the screw from the GT to the femoral head instead. And maybe medial plate at the distal if the screw fixation is not enough. That's my opinion.
Thank you for recommendation from panelists. Can I ask about the what kind of the implant we will put on the medial plate? What implant that you choose?
I choose a Philos or even maybe use the low bend distal tibial LCP. And for the proximal fixation, you might need a locking attachment plate in because the bone is quite small and the nail is quite large, and the locking attachment plate could be easy to put a cortical screw around the nail.
Okay.
May I quite like to to join this issues. Sometimes we have difficulty in trying to fix the medial side. I have been since some of the company has invented the new kind of anatomical locking plate for the medial side. But from China, maybe you taking this into considerations. It has really quite robust of the screw hole at the distal fixations and a little bit more to the proximal fixation if you like to get very secure.
All right.
But now from the synthesis, I think there's no medial plate invented yet.
Yeah. No, in our marketing.
Yeah.
Okay. Process with this case. So consider our finding. We are faced with the spectrum of management option. The challenge is severe osteoporosis, very fragile, shock segment with some comminution. Our management is we operation on radiolucent table, the lateral incision with Meeple fashion first, and then medial subaortic approach. So the implant we select the distal femoral LCP and contour along Philos. Step by step, lateral approach first, and we try to temporary fixation with the KY and preliminary place the plate for see that is go along the canal and the proper length of the plate. We remove two locking screw at the intermediate in the old PFNA because we think that it may interfere the direction of the new screw. We direct traction and manipulation. And then we place LCP to the distal fragment, temporary fixation with the KY, check proximal and distal fragment. You will see that, we fix locking screw distally and proximally, but the proximal fragment, that's the key. You will see that the cortical screw at the proximal side is very, when we tight, slowly tight is quite feeling like some loosening, not tight enough. So we will change the plan from the screw to put a wide mount and put a circuit wiring here. And then we preliminarily place the lateral plate, and then we move to medial subaortic approach, what performed. We contour the Philos, long Philos was applied with a contour to the anterior side. And then go on fixation as planned. We check the alignment at the hip knee angle. Okay, you see that in the lateral view, we twist the phylos to the anterior for get the direction, not interfere to the old PFNA implant. And then unicortical and bicortical will insert for further stabilize the fracture. Okay, this is the port of film. So our rehabilitation protocol, we allow patient through non-weight bearing around 3 weeks and then slowly get her put a toe touch on weight bearing and gradually weight bearing 10 kilo per 2 weeks. For last 6 months, she is doing well. Some like quadriceps weak, but she can ambulate well. Thank you. Any question?
I have some question about the management. This you plan to put the parallel dual plate at the first plan or to try to fixation only one plate first?
Okay, we plan to put the 2 plate at the first size because I think there's like the short segment and some comminution we see and the CT. I think the just 1 plate maybe not enough for strength of the fixation. Maybe we have to ask them. We plan to stabilize with medial plate first.
I think the concern point is not the fixation at the distal part is quite, you can put more than 5 screws in, but for the proximal part, that is not too much secure. If the proximal part is quite secure, do you intend to put the dual plate, right?
The proximal part, okay, we secure with the circular wire, with the unicortical as we can, but by the way, from the short segment and osteoporosis, like maybe it's difficult to prognosis the healing by just the 1 plate. I think the medial plate is more secure, and we do like the Savatat medial approach. Try to not invasive but supply at that area. Yeah, I think it's a proper treatment.
For the another patient that have any issue about remove the distal locks
Okay.
to school, we have any intention to do something?
Pardon, you mean that?
Remove the distal lock.
Uh-huh.
Yeah. What is the plan that you remove? That is the reason you remove the distal
okay.
lock.
We at the first we plan that not to remove if it didn't interfere the direction of screw. But by the way, you can see that we plan to put the dual plate at the first side. We may think that the screw may have to interfere together, and the all of this locking have to obstruct our plan. So we go into the intra-op and we can see the 2 screw, and we remove at the first phase of the operation.
Did you intend to reposition it back after the surgery, after the plate?
Okay. We didn't plan to put back. Yeah, because I think we secure with all the screw.
Yes. Any question for the panelists for this case?
Professor Suthorn, please.
Hello. Yeah, I'd like to draw attention to many of us when doing intertrochanteric, we prefer to use a long one or short one, although the literature does not support the advantage of a long one. But the idea of having a long one is to splint the whole femur to prevent further fracture. But I have seen more cases that you have a fracture at the end of the nail, because you cannot splint until subcortical bone. So I'm not sure whether this is a right decision when you're using a long nail. Right? I have no answer, but I think you have to be aware of the situation where you have this, right? Because, and sometimes if you do too long, it will perforate anterior cortex. So that is another issue. So it has to be very careful to select the long one if unnecessary. More and more today, we try to put the plate on both sides, although there are definite indication. The reason is if you open both sides at the same time, you are much easier to reduce any fracture. Right? In the past, we tried first on the lateral, and very difficult to manipulate or even to reduce the fracture. Right? If you open on both sides, in many cases, even easier, you reduce on the medial side first. Once you put KY temporary, then you can put the plate. Right? And to put the plate on the medial, in this case, of course, but I don't think you need such a strong implant like this, you know. But it has advantage of bicondylar as usual. And because on the medial, it's not much of the destroy of the vascularity. You just go subvestus, right? And that allow the patient in most of the time to start weight bearing because they are very old. And even you fix lateral, you think I'm satisfied. There are many cases because of osteoporosis, the plates start to move. And you don't want to reoperate this case, right? So nowadays, there are more and more tendency to put the plate on the medial. Thank you.
Thank you, Dr. Suthorn, for commentation. We will go to another session and new case and new moderator, co-moderator. Okay, thank you very much.